Hello. Good afternoon, good morning, maybe. Good evening.
Morning. So hello, everybody, and thank you very much for joining us. This afternoon, we have Jay Manik from the UK. Jay is a well-known laryngologist, and he's going to be talking about laser surgery for cancer of the vocal cord. Jay, can you hear me?
Yes, of course. I can hear you very
Okay.
well.
Thank you very much for joining us. Jay is a star here on the our program. He always, whenever any of the speakers ask a question, Jay is just guessed it immediately, without any hesitation. So I think you're going to enjoy today's talk. Please go ahead, Jay, and you could share your screen. I think you should be able to do it now.
It cannot start.
Is it doing it?
My other participant. Yeah.
Here we go. I think you should be able to do it now.
I'm struggling here. It says you cannot start screen share while other participant is sharing.
But nobody is sharing. I'm not sharing anything. Oh, okay. Yes, you're right. I'm sorry. Yes, absolutely. Just give me just 1 second. Let me just 1 second. You are right. I am sharing a video. But let me just give me just 2 seconds.
No worries at all. It says sharing computer sound.
I know. And usually I get like a message here telling me that I'm sharing something, that I cannot get it here. Recording. They're using encryption. Okay, I'm just going to share some random stuff and then I'm going to come back. Okay. So I'm going to stop share. Okay, now you should be able to do it.
Yep.
Thank you, Jay. Sorry for the confusion.
No worries at all.
Great. Yeah, we see it.
Good. Am I okay to start or wait for a few minutes?
Yeah, please go ahead.
Okay, good. Can all of you see my screen? Am I right?
Yes, absolutely.
Yeah.
If you could get close to the speaker, I think the sound is a bit low.
Is it? Okay. Right. Is it better?
I think so. Yeah.
Okay, great. So good evening, everyone. I'm Dr. Jay Manik, ENT consultant from Nine Wells Hospital, Dundee. And Salam Alaikum, am I saying correctly?
Yep. Absolutely.
Great, thank you. Good. This talk is about a laser surgery in laryngeal cancer. I'm going to briefly touch base how to classify laryngeal cancers. What are the techniques you can use to do a proper laser surgery, and some evidence. Why it is important, laryngeal cancer? 2,400 patients are diagnosed with laryngeal carcinoma every year, and 800 patients die of laryngeal cancer, even in the UK. So there is a two distinct classification or division. One is early laryngeal cancer, the other one is advanced laryngeal cancer. It is a dangerous game. In case you missed again, yes, it is a dangerous game in terms of laryngeal cancer or management of laryngeal cancer. For brief classification or for a glottis, we all know that T1 is a very small tumor limited to vocal cords. T2, it involves more than one subsite, could be supraglottis or subglottis. And T3 is involving the vocal cord muscles, so it's a fixation, or it could involve paraglottic space. And T4 is involving a thyroid cartilage. So what we call is a T1 and T2 is early laryngeal cancer, and T3 and T4 advanced laryngeal cancer. The whole talk is about these three. I mean, this single slide will give you answer for everything. There are three options in the management of laryngeal cancer. You could use laser, or you could use a radiotherapy, or you could use a partial laryngectomy technique. The lasers are economical, it's convenient, you can repeat as many as times, but you need a good skill set, and it does provide a good outcome. Radiotherapy can provide a good outcome, but it is a one-shot procedure. You can't repeat as many as time like a laser. Partial laryngectomy is common in Europe, which is one of the unique skill. Again, it needs a multidisciplinary approach in terms of swallowing and speech rehabilitation. You can see there's the three different types in the bottom. Do you know, anyone knows what is this one? Have you been in Lanzarote? Full of volcanic land. They use the ground. There's a hot air kind of coming from the ground. Within 30 minutes, they can roast the whole chicken. It's actually faster than the proper oven and log wood. Yes, there are different ways to treat a cancer, especially laryngeal cancer. So let's see some interesting pictures here. It's in the first slide, you see a small lesion there. That's also T1. On this slide, second picture, you see a larger lesion. That's also T1. And this one is a broad and diffuse, a slightly bulky lesion. That's also T1. And this one on the bottom is a diffuse, kind of superficial and deep infiltrative lesion. It's all of them considered as a T1. Okay, so it's not just simply say we got a T1 lesion, right? So what is this stage? You can chat, you can put this message in the chat. Anyone knows, is this T1 or T2 or T3? Definitely it is not T3. Definitely it is not T4. Maybe I can give you a clue. The lesion is still limited to the one card, but it's going across. It's involving the anterior commissure. It's two lesions, and this is completely involving the anterior commissure and goes like a kind of diffuse lesions. The reason I'm just highlighting these things, when you do diagnostic endoscopy, you need to clearly document these images. It helps the laser surgeon to plan his operation. Laser surgery is similar to the cholesteatoma surgery. Many of my bosses are good otologists who kind of turned into the laser surgeon. So you need to have a clear plan. So that will improve your laser outcome. So this is a further stage, slightly bigger than the previous two. It goes all around from the one card to all the way to the anterior commissure, but it's involving the more than one subsite. This is a large lesion, and this is also a large lesion. This is all T2. Still it's T2 because it's involving just more than one subsite. This is clearly T3. You can see it's a large, bulky lesion, and the T3 lesion usually diagnosed by clinical examination when the vocal cord is fixed, you can clearly say, or radiologically, it's just going into the paraglottic space. So this is T3. Particularly this one, it's a radiorecurrent T3. The patient was treated by for T1 cancer with the radiotherapy. Now it has come back. This is clearly T4, large lesion. I'm performing total laryngectomy. Okay, so that's the basic disease classification. If you have any questions, just chat, then I will answer at the end about the staging. So when you do laser surgery, you need a laser setup. How do you set up the laser? You need a good laser safe anesthetic team and safety officer who can run a laser machine, checking the laser machine to make sure everything is coming under safety regulations. So there are two broad classification. How do you give anesthesia for the laser? Either you could prefer tubeless approach, which you can use Optiflow catheter. This is Hand-Sacker tube, or jet ventilation, or spontaneous breathing. Or you could go for a laser-safe endotracheal tube. In broadly, I use laser-safe endotracheal tubes. If I go for a tubeless field, I'll go for a catheter. I will discuss this with my anesthetist. We always plan. For planning, you need a diagnostic endoscopy pictures so that the anesthetist will give you, okay, you're going to struggle in this case, I will give you tubeless field. Or the lesion is more anterior, the tube sits in the intra-arytenoid area, so you can work very well with the tube, we go with the tube. So that's how you need to plan. This is a tubeless field. The patient goes for a spontaneous kind of ventilation, oxygenation. Then I'm performing something in the posterior card. That's why the anesthetist gave you a tubeless field. Actually, this case is a laser cordotomy for bilateral vocal cord palsy. Instead of tracheostomy, we do laser cordotomy. So this is a simple small lesion in both vocal cords, you see. When you do the biopsy, the right card showed carcinoma in situ, and the left card showed a left side modified dysplasia. So how do we treat this? I'm just showing a short video which shows I'm using the CO2 laser, AccuBlade, and using 4 watts, repeat mode to start with. I'm grasping the lesion with a cup forces. It's very, very similar to the cholesteatoma surgery. Gentle, don't add too much, make sure there's no charring, and cut along the superficial layer just above the ring keys. So I'm performing a type 1 cordectomy. And on the other side, just using the right angle. With a laser, you can use a dot or a line or a circle or even angle type of things. I prefer AccuBlade because it does provide less charring. The whole procedure normally takes 10 to 15 minutes when you start doing more and more. This is just immediate post-op. So this type 1, type 2 cordectomies we will discuss more later. This is European laryngology classification, how adept you are cutting with laser. If you cut only the epithelium, type 1. If you go a little bit more deeper into ring key space, type 2. Type 3 involving the muscle, ocalis muscle. Type 4 and type 5, bit more extensive, or could include arytenoids or anterior commissure or false cord. Just example, I'm performing this case. I have done a superficial. You can see the muscle, ocalis muscle, beautifully underneath with the ring keys. That's type 1 cordectomy. And this is 6 weeks post-op, how it heals up. This is type 2 cordectomy. You can see the ocalis muscle a bit more deeper. And this is type 3 cordectomy. You can see this is ocalis muscle I have removed partially. This is epithelium. This is a Rinke space, and this is vocalis muscle. This is actually type 3 cordectomy, and you see how it heals up in 8 weeks' time beautifully. If you perform a vocal cord surgery without much charring, that gives you a beautiful result.
Jay, can I interrupt for a second?
Yes, please.
I'm going to show like some taking poll and asking people questions. I hope you don't mind that during the presentation. You just have to ignore that window.
Absolutely. Absolutely. I like that. Thank you. So this is actually a lesion involving the left vocal cord. And the biopsy showed actually carcinoma in situ here, moderate dysplasia here, and severe dysplasia here. Especially for beginners, when you take a biopsy of this lesion, don't take biopsy in one area. If there is a diffuse lesion, you must take biopsy in multiple areas because sometimes the disease might be kind of hidden. So how do you treat this patient? Can you kind of text in the QA, do you offer radiotherapy, or do you offer laser surgery, or do you offer partial laryngectomy for this patient? Once again, repeat, the lesion in this area came back as a carcinoma in situ, and this area is moderate dysplasia and here severe dysplasia. So he is around 55-year-old, is a kind of a school teacher by occupation. He is a smoker, stopped a week ago. But I'll tell you how I treated this patient. I did perform a transoral laser surgery. You can see that I used a type 1 cordectomy to start with, type 2 here, and type 3 here. And that's a 6 weeks post-op. It does heal up nicely, but I'm not saying that this is the only treatment we can offer. This is what I did, right?
For my voice box, and I'm able to talk all right, and no problems at all with it. Very happy with it, in fact.
So just for a bullet points, in these cases, T1 and T2 cancer, if you treat with a laser surgery, it gives you a good oncological outcome, and there is a higher chance of laryngeal preservation. Anterior commissure is a risk factor if you look at this one, but if there is a deep involvement, you may have to consider radiotherapy. However, if you're experienced, you could consider laser surgery for anterior commissure involvement with a good voice outcome. This is a slightly bulkier T1 lesion. And if you look at that card, that's a normal card on the left-hand side. This is a large lesion. But if you look at that carefully, the vocal cord ends here. Actually, the lesion goes a bit more deeper here. So if you resect it, it doesn't give you a bad outcome. You see that one. I have used the laser and treating this with a type 3 or type 2 cordectomy. This is the initial picture. I'm using a patties just below the lesion. I'm palpating the lesion. That's the important technique. It gives you the depth of invasion. I'm making a marking cuts with intermittent mode. Once it is done, I gently use the cup forceps to pull the lesion medially and start using the repeat mode and extending the further cuts. Actually, I'm still doing type 2 cordectomy. The muscle is free underneath. The vocal ligament is underneath. When you start doing more and more, similar to the autology surgery, you know where the facial nerve is, you know where the stapedial tendon is. Similar to that, you will understand which is vocalis muscle, which is a ligament. Always, I perform 6 weeks post-op look, and this is, you can see within 6 weeks how it healed up. The only difference is on this card, it's more striped and tense. In fact, that gives the best voice outcome, especially for aging voice. So in fact, laser surgery can give you a better voice outcome for some of the patients like that.
I feel fine, yes.
Is your voice?
It's still a wee bit gruff, but
It's fine.
it's fine, yes. Yes.
Your swallowing is all right.
Yes.
Okay. Then there is another lesion. We're talking about almost entire.
I'm in here for my operation in July, I think it was the 20th, and I had the laser op done and the lump removed, and then back in again for the second look just to see what's there, and then later on about another 6 weeks I think I'm back in again for another look.
Yeah, see the voice quality in 6 weeks. If there is a large lesion, the recommendation is you could do a 6 weeks post laser resection and examination under anesthesia. But if you have excellent stacks like Olympus or other stacks, you could even see in 6 weeks in the outpatient endoscopy itself whether there is any recurrence there or not. Right. This is a common case. I want you to respond in the Q&A. How do you treat these patients? Do you use laser? Do you use radiotherapy? Because the biopsy which you have taken here all shows carcinoma in situ everywhere, but there is no invasion. But it's all carcinoma in situ. Is a chronic smoker, obese, severe reflux, ongoing. It's one of the common patients you come across in the Western world. So there is a guidelines here. Is it mild and moderate dysplasia? If it is recurrent and focal, you can excise it with the laser. But if it is severe dysplasia with persistent the risk factors like smoking, alcohol, then you have to consider treating this as a T1 cancer. Okay. So if it is persistent or recurrent, widespread, radiotherapy should be considered. But if it is focal, still you can use a laser. This is the cucumber specimen. So laser, I said, it's a teamwork. Once you excise this lesion, we paste this in the cucumber specimen with the glue, like a vocal cord. So this is the right vocal cord lesion. This is the posterior margin. This is the medial margin. This is superior margin. And so when the pathologist slice it, they will come back and say which margin is involved. So it's easier if there is any involvement in the 6 weeks time, you can go back and remove that particular part that preserve the voice quality. You don't have to remove everything in future. So you have to understand the laser principles of the laser surgery. It's not like cutting with a knife. The cold knife, yes, you cut here, it opens up. But when you cut with the laser, it forms a V-shaped defect because it's due to vaporization and photocoagulation. So you don't need to worry about the histological margin. That is the point I'm trying to make here. So that's why even if the pathologists say there is a lesion in the margin, you don't have to worry because you're going to char 3 millimeter on either side with your laser. So this is another case with multiple dysplasias, carcinoma in situ. I have used a laser as a kind of like using the butter knife, and then there is a recurrence over there in 6 weeks, then I have used again. So this is another lesion in the anterior commissure. This was removed by a 2-stage laser excision. The first one is removing only this part. Then I went back after 6 weeks and removed this bit. Yeah. So, but what exactly this is what happened. This is the first lesion was removed, and this is the second one. But you do get stenosis here, web here, but it doesn't matter. If it is progressive, it matters, but most of the times it doesn't progress. The only problem is there may be a lesion, second lesion, or further lesion, which might need a close clinical monitoring. Okay. So this is a large anterior commissure lesion. One of the other options is offering radiotherapy to the patient, but this patient I treated with transforaminal laser surgery. If you see that, it does look bad. Okay, when you do the laser operation, you think, oh, did I overdo it? But if you look at that, I still preserve the muscle here. There's a partially torn vocal cord muscle there, and there is a rinky space mucosa, and there's a epithelium there. And you see the intraop pictures. This is the anterior commissure lesion. It does look bad. Okay, you agree with me, right? Because it's extensive resection. That's how it looks. It heals up in 6 weeks' time. What you see is there's a little bowing there, and possibly there's more bowing in the pulse cord region, and that's how it heals up. So my argument or question is, why do we underuse laser? It does heal up beautifully if you use, because the technology has improved. If you use latest lasers, it does provide a very good, and also you need a good skill set as well. This is another anterior commissure lesion, which was
transmission unit.
and
The materials that I got for the clutches were faulty, and I had to repair the whole thing myself out of reusable material which was lying in my workshop.
So that's his voice. Yep. This is another lesion, which is involving both vocal cords, and treated with transforaminal laser surgery. And
I have been diagnosed with cancer in the voice box. Today I had my first laser operation
immediate post-voice.
to remove one side and the middle part. To me it's been very, very successful, although I shall return in 6 weeks' time to do the second part. I feel good. Afternoon, hello. I am back here again at Ninewells Hospital, looking forward to my second part of my laser treatment.
So that's how, when we resected it, that's how the first picture after the resection, that's how it healed up. You see this epithelial pearl, like a cholesteatoma pearl, recurrence. That's how it pulls laterally. Then during the second resection, you go and resect this one. That's what I did on this side. So what are the evidences? Rescue plan for everything, because laser surgery is always you need a skill set and repeat follow-up, or sometimes you may have to change your plan in the last minute. So that's the important thing. It's a few more cases, but I want to show this one. This case was actually referred from the different center. This is an anterior commissure lesion, which we can't do it with a laser, so we resect it. So let's go for a radiotherapy. But actually, when you see that, this is the lesion. be treated with a laser. So the important point here is when you do take a nice photos, it's better to use a 30-degree endoscopes and 0-degree endoscope and get multiple views, especially passing the 30-degree endoscope in between the vocal cords and to see the undersurface. That will help to especially discuss this laser surgery with the patient, especially concentrating more on the voice outcome as well as oncological outcome. Just to quickly summarize again, that's what we have discussed so far. Laser surgery, we can repeat as many as time. It's cost effective. The initial setup is expensive, but once you've done that, then it's become, because you can use the same laser machines to the different departments in the hospital. You need to have a good skill set, proper team, but you could consider radiotherapy as well, but it goes for 6 weeks. Think about the quality of life for 6 weeks with a one-time procedure. And if you think about the patient is a carer for the whole family, you'll be away for like literally 2 to 3 months for the treatment. And partial laryngectomy is also a debilitating procedure. We don't do it in UK commonly, but it's very popular in Europe. But I'm just going to talk about the downside of the laser. This is a large lesion. I performed transfemoral laser surgery. You can see type 3 cordectomy, and there is something has come back. Yes, it can come back. And so you can further do laser surgery, or you could offer still radiotherapy. So that's because you're preserving radiotherapy for recurrent or residual cases. There's a nice guideline from Journal of Laryngology and Otology, was edited by my ex-boss, Professor Pellery. Just for the recommendation is, you could offer transfemoral laser surgery and radiotherapy for T1A and T2A. Both need to be discussed with the patient. And you should explain in an unbiased manner, because some patients still prefer to have radiotherapy. Suppose if they have a poor access or they are unfit for surgery, still we could offer a radiotherapy. But at the same time, transfemoral laser surgery is also equally a good surgery, and even major surgeries can be done within 40 minutes, and we do this as a day case procedure. Supraglottic laryngectomy or open partial laryngectomy may have a role. And quickly, this is, as I said, this is a radio recurrent cases. She's a 92-year-old lady. You can't offer radiotherapy. So what we have done is we used a laser for doing partial laryngectomy. This is my technique is called a double pyramid technique. It was published as well. It's one of the quickest way of doing the operation. You just go and do a radical operation inside, which means you go inside, cuff along the larynx, and this is, you see this, you make a keyhole there. What you see is a subcutaneous fat prolapsing between the cricothyroid, cricotracheal area. And you see at 6 months post-op how the voice.
I think.
Okay. Is your voice getting stronger?
Yes.
Okay, good. How's your swallowing?
Pardon?
Who?
Oh, fine.
Fine.
No problem.
Who is he?
That's my son.
Okay, is he looking after you well?
Yes.
Yes, so for those cases, a total laryngectomy is an option for radiorecurrent tumors, but you can't do total laryngectomy for a 92-year-old with a wheelchair bound, but you could offer laser surgery. They do have a husky voice, but there's no valve, no stoma problems, no swallowing problems, no aspiration, because as long as you have epiglottis there. Anyone knows what it is? This is, I want you to come back as well. This is not a laser charring. This something bad happened while I was doing the operation. So then I proceeded further down to look at the bronchus to make sure everything is okay. So maybe we'll discuss that in that one. So just for summarizing, for choosing the laser cases, make sure you got a good access. And while performing the laser operations, similar to the cholesteatoma surgery, make sure it's bloodless. And you have to understand the 5-dimensional traction principle. It's very similar to the performing tonsillectomy in a keyhole. So you need to push or pull or drag the lesion up, down, more medially, laterally, so that you create a space. It's a progressive resection. That if you understand that principle, you can do a beautiful laser surgery. You need to have a good setup, good anesthetists, good laser officers, and you have to understand you may have to go for some courses to develop your skills, or you could conduct courses. You need to have a good trainer. That's my boss from Freeman Hospital, Newcastle. I do run a laser course in Kushari Skills Center, Dundee, and that's a team. This is my conference, which I'm the conference master for 2020. In September, we discuss about only complications and the management in head and neck surgery. Nearly 27 people attending as a faculty all around the globe. You could go to the website headandneckconference.co.uk or Dundee Institute of Head and Neck Education as a Facebook group. I think that's it really. We don't need to discuss more about advanced laryngeal cancer. So I'm happy to take any question.
So I have to apologize for the group, in that we have like some sort of what they call Zoom bombers. They came in and they did like some bad comments on the chat. So please ignore the bad comments. I removed them from the meetings.
Oh,
there's some good questions on the chat line. If you could ignore the bad comments and
no, not at all, not at all. That's fine. Good. So I need to go to the
chat line, please.
Chat line. That's good. That's good. Good to know. Right. Okay. The staging, what we are talking about was actually, that is also this is also T1. The T1 involves only one subside, but it's a T1B because it involves both sides. So that was the question for T1. And the next question is, so many hi, so many please, thank you. Good. Right. Will stroboscope pick up the lesion that has infiltrated the vocal ligament? Yes, that's a good question. Yes, it can. Some of the surgeons after surgery, they still use, see them in the voice clinic, they use to improve their voice. That's good. Do you do hydrodissection before type 1 correctomy? The answer is, it's a good question again. No, I don't. I don't think it's necessary because When you do type 1, you work just above a Rinke space that itself has got a lot of fluid. If you use more fluid, the CO2 laser get absorbed in the water, so it doesn't really give you the best cutting outcome, and that's my experience. Thanks, Mr. So for these cases you have shown, do you extubate them post-op, or you rest the larynx with some ventilation? Do you need a tracheostomy, any of them? And do you routinely cover with PPIs? That's a very good question. I don't do any tracheostomies for transoral laser surgery because, in fact, you widen the airway, you remove the lesion. So they never develop any stridor or anything like that. I always advise them for voice rest for a first 1 week, no whispering, no shouting, but they can talk. I advise them to take plenty of water, 2 liters per water per day, more hydration, avoid fizzy drinks. Similar, I don't prescribe PPIs, but I advise them to avoid a reflex thing. And do you some ventilation? I don't do. Always we extubate them. We never keep them in the ITU. We do it as a day case procedure. For lesion at the anterior glottis, anterior commissural region, how can we be very sure that it is not involved the inner cortex or outer cortex of the thyroid cartilage if no scan is done? As involvement is inner outer cortex would immediately upstage a tumor T1 to T3, T4. That's a very good question. We always perform a CT scan for laryngeal cancer. And the CT scan is quick, 3 to 4 minutes, and nowadays it's not expensive. So I would strongly recommend to do the CT scan. Also, it is mandatory in the UK perform a CT chest as well, because they may develop other lesions in the lung or second primary. That's very common in smokers. Lung cancer is equally common. We do pick up. It's hard to say without the CT scan, or you will find out during the operation. Then you might say it's going more into the deeper to the cartilage. Your thoughts about partial laryngectomy, the criteria, please. Yes, partial laryngectomies I perform, especially with the laser. And Europe, they do external partial laryngectomy. Partial laryngectomies, it depends upon the extent of the disease. If you have a fit patient, somewhere around 70, without any aspiration or diabetes, they are all the very good candidate for partial laryngectomy, because they do develop some aspiration. They need intensive supraglottic swallow by speech and language therapist, and they need to be prepared at least 6 weeks before the operation. So if you have done those things, partial laryngectomy is a good, but if you perform this procedure very occasionally, I wouldn't recommend. It needs to be done in a large kind of volume centers on a regular manner so that everyone know what they're doing. Borak, very honest and practical. The AccuBlade is amazing. I do love that AccuBlade. The reason for the AccuBlade is actually it keeps on moving in between the line, so that unlike the AccuSpot, you need to keep on moving to prevent charring. So it does help. Post-operative treatment protocol you follow after doing cordectomy. As I said earlier, voice rest, day case procedure, more hydration, and I do prescribe some steam inhalation on a regular basis or a zona. Laser fire, very good. That's the correct answer. Yes, I showed you some kind of charting pictures. I was performing a 86-year-old lady with a second revision. My registrar was doing something, then after that I had to perform the procedure. It wasn't difficult, but I caused the fire, not my registrar. Then what happened, we were using the tubeless technique, using jet ventilation on that occasion. And the patty we usually keep is a wet patty. Because of the jet ventilation, the wet patty dried up. So at the end of the 40 minutes procedure, there was a sudden kind of gush of fire come out of this tube. It lasted only 30 seconds, then it stopped because the patty was the one causing the fire. And there was no distal damage, so I a little bit panicked. Then after that, I did a bronchoscopy to see whether there is any distal injury. There wasn't any injury, and I contacted the respiratory physicians. We started some low-dose steroids, kept her in the hospital for 4 or 5 days. Then she went home. Then it healed up beautifully, but it can be dangerous as well. So what you need to do, especially these cases, better to operate this kind of cases with a large monitor. And that's why I said you need a good team. The laser safety officer's role is keep reminding you. So we change the policy every 5 minutes or 10 minutes. They change the patties to make sure everything is wet, because for a laser fire, you need 3 things. One is oxygen, and the fire igniter, and the medium which can get the fire. So the patty is the main culprit most of the times. That needs to be wet all the time. So if that fire happens, what you really need to do, there's an assistant nurse should have 100 ml of syringe with the cold water. Just needs to, that's the first step. You need to do that one. And then obviously inform the anesthetist, and also try and, if there is a tube, try and pull it out. And then that thing, I think that's the most of the things. It can be dangerous, and also you need to be open and honest and explain to the family and everyone. It is well known complication. So you need to consent that before. I have performed nearly 360 procedures in 5 years. In Dundee, we have 1 laser fire, but actually it's underreported. Many, they don't report it. I read it after the incident. Even in US, it's nearly 2,500 laser fires or airway fire happens every year. And they think only 1/3 is being reported. So we are expecting nearly 7,500 laser fires. It's not necessary it's a laser fire. You could use a monopolar. Then that causes fire as well in that area. And that's all considered as airway fire. The next question is, I had only one question. You did find some advantage or benefits if you do before removal of the tumor. Benefits if you do before removal of the tumor, previously injection with a normal saline. Normally, I don't do any injections with a normal saline. Do you transect the tumor and excise in 2 parts? Yes, if necessary, we do excise it in 2 parts. So that doesn't compromise the oncological outcomes. And the most important thing is when you resect the tumor, when you put it back in the, the cucumber specimen, you need to glue it so that it doesn't confuse the pathologist. So that's all you need to do extra. And criteria for open and partial laryngectomy, we have discussed before. I had only one question. Did you find, okay.
There's one question here. I had to limit the access to the chat line. So
Right.
some of the questions were coming to me. There's a question about the margin. Margin in terms of like how much margin you get when you have a carcinoma in situ versus a carcinoma.
That's a good question. To be honest, you don't need to worry about the margins. Once you resected the tumor, then takes biopsies from the patient side. That is going to give you the margin. Or you could, for a T1 cancers, I would say 1 to 2 millimeter is more than enough. It's not like a centimeter, like a skin lesion. It's a vocal cord lesion. 1 to 2 millimeter is more than enough, but I always do the second look. When you go to the second look, you can scrape it a bit more second time.
A second question is from Dr. Kadash. Do you know about a good study comparing voice outcomes, laser surgery, comparison with radiotherapy?
Yes, actually, I'll show you the brief one, and there's no randomized control trials, but there are shows. I can show you this one. Treatment of T1B subglottic glottic cancer radiation laser is a Canadian multi-center study, was published in 2013, head and neck surgery. It does show there's no difference, to be honest.
There's two other questions we want to look at the chat line. The last two questions from Kia Shah and from N. How deep can you cut safely? You see those?
So how deep can you cut safely for transoral laser surgery? Can we go beyond the outer cortex of the cartilage and excise safely? I guess the outer cartilage, I didn't understand your question, unfortunately. When you can go up to the perichondrium, so it's that is type 5 cordectomy. That I guess that's what you meant, I think. Yes, you can go up to the perichondrium. And the one I did, the radiorecurrent partial laryngectomy with a laser, you go up to the cartilage, but you don't cut it with the cartilage, and you go up to the perichondrium and take it out there. What is the difference margin distance? That's one. Do you know any good study comparing voice outcome? That's what the Canadian study is there. Do you use the frozen section of the margins to ensure complete resection in every case? And the answer is no. Frozen section is not very reliable because it takes literally 40 to 50 minutes as well. And the whole procedure, laser procedure itself, is 30 to 40 minutes. And we routinely perform 6 weeks second look, or nowadays we have a high definition cameras and endoscopies. We can easily have a look again. So it's not necessary for frozen section. What is the recurrence rate for partial laryngectomy, sir? The partial laryngectomy and transoral laser and radiotherapy for a T1 cancers, the recurrence rate is actually less than 5% in good centers. So it's all the three can provide a good oncological outcome for T1 and T2.
Great. Well, would you, there's one more from Dr. Kalash. Did you see it? Would you stent a T1B case instead of staging?
Would you stent T1B cases instead of staging? Oh, that's a good question. No. And the answer is no. I do perform a lot of anterior commissure. T1B, he meant it's anterior commissure involvement. I don't do stenting, but I do a two-stage procedure, one on the right-hand side, the other one on the left-hand side. For one stage, you can resect it and put a stenting. I think that's too uncomfortable. I don't think it's necessary. So it's better to have a two-stage, because you're going to have a look again in 6 weeks' time. That again gives you a confirmation whether the disease has recurred or not. So it's I don't do stenting.
All right, well, thank you very much. I really enjoyed your talk. Appreciate you being with us, and good evening to everyone, and hopefully we'll see you tomorrow evening.
Brilliant. Thank you very much. Feel free to join the Scottish Head and Neck Conference. It's free, and I think we have already 700 participants from 70 countries. So hopefully I don't get any Zoom bomb. It's going to be in Zoom.
All right, so you take care. You have a nice day.
And you're doing an amazing job. I really like it. And I'm usually a silent participant. And I think it's a hard work what you're doing. I wish you continue that because it's so difficult to coordinate these people and doing this more religiously every few days in a week. That's really a great job. Thank you. And thank you very much to all people. Okay. Thank you.
All right, so you take care, guys. Have a nice day. Bye-bye.